What's up, Ninja Nerds? In this video, we're going to be talking about ischemic and hemorrhagic strokes as well as TIA. And we're going to be covering the most important information, also known as the high yield information, that is necessary for you guys to excel and pass those exams. Before we get started, it is so important if you guys can continue to support us by hitting that like button, commenting down in the comment section, and most importantly, subscribing. All right, Ninja Nerds, let's get into it. All right, Ninja Nerds, so before we start talking about the etiology and pathophysiology of the different types of strokes, we have to understand our basic anatomy and physiology. And that's where understanding the cerebrovascular system, the circle of Willis, comes in handy. So let's talk about the vessels that are involved in the anterior circulation. So how does this work? Left ventricle pumps blood into the aorta. From the aorta, it'll go up through the carotid arteries. Now you got two common carotid arteries. From the common carotid arteries, they'll branch into external and internal carotid arteries, which are these guys right there. The internal carotid arteries are important because they feed into the anterior circulation. And from the anterior circulation, there's the corresponding vessels. Here's our internal carotid. This one here is called your posterior communicating artery. This one here is called your middle cerebral artery. This one that's kind of connecting between this side and this side right here is called your anterior communicating artery. And then the vessels that are coming off of that anterior communicating artery system is your anterior cerebral arteries. So to recap it, what are the most important vessels that are involved in your anterior circulation? Your internal carotids, your anterior cerebral artery, and your middle cerebral arteries. Posterior circulation is the other aspect of the circle of Willis that we should know. If we follow these up, it starts with your subclavian vessels. They give off vertebrals. Vertebrals kind of work their way backwards and upwards. When the vertebrals are coming off, they give off branches off the side called the posterior inferior cerebellar artery. They also give these ones here in the middle, which I did not write, called the anterior spinal artery. The vertebrals come together, fuse, and make the basilar artery. Then the basilar artery will work its way up through the brainstem, giving off branches sequentially, such as the anterior inferior cerebellar artery, superior cerebellar artery, and then finally the posterior cerebral artery. And look what connects at that point of the posterior circulation. The posterior communicating arteries, and that gives you that classic circle of Willis. Okay, so big vessels for the posterior circulation include posterior cerebral artery, basilar artery, and vertebral artery, but don't forget about the branches that come off of those guys. All right, so we've covered the basic anatomy of the cerebrovascular system. Now we have to have a basic understanding of the physiology. Those vessels, they supply particular areas of the brain and brainstem. So if there's an occlusion or rupture of that vessel, it'll produce neurodeficits depending upon the location or part of the brain and brainstem it supplies. So basic thing to take away from here. Anterior cerebral artery supplies the medial frontal and parietal lobe. Okay? Middle cerebral artery supplies the lateral frontal and parietal lobe as well as the temporal lobe. There's another big thing that you need to remember for the MCA. The MCA, if you look deep within the actual brain, in the subcortical portion of it, it gives off these little vessels called lenticulostriate arteries. And the lenticulostriate arteries supply these structures here that are part of what's called your basal ganglia, which are made up of your caudate nucleus, your putamen, which is made up of the lentiform nucleus, which is the putamen, also the globus pallidus, as well as the internal capsule. These are important things to remember. The last thing I want you to remember for the physiology of anterior circulation is I was saying frontal portion of the medial portion of the frontal and parietal lobe. We know in your frontal lobe you have what's called the primary motor cortex. Well, the primary motor cortex is where motor neurons are present that control voluntary movement of skeletal muscles. What I want you to know is the medial portion of that motor cortex, which supplies the legs, is controlled by the ACA. The lateral portion of the frontal lobe, the primary motor cortex, which is supplied by the MCA, controls your arms and your face. Lastly, if we look at the parietal lobe, where the somatosensory cortex is, the medial portion is supplied by the ACA, and that's sensations that are coming from the legs. The lateral portion of that somatosensory cortex, or the parietal lobe, is supplied by the MCA, and that's responsible for sensations from the arms and the face. Finally, let's talk about the importance of the posterior circulation. The posterior cerebral artery, I want you guys to remember it supplies the occipital lobe. It also supplies a part of the temporal lobe. It also supplies the thalamus and the midbrain. Very important. The basilar artery and its branches supply the pons as well as the superior, anterior, and inferior aspect of the cerebellum. And then the vertebral arteries and its branches supply the medulla and the posterior and inferior aspect of the cerebellum. That gives us the basic understanding of our anatomy and physiology. Now we can talk about causes and pathophys. All right, so now let's talk about causes and pathophysiology for strokes. And again, when we're talking about strokes, we're talking about ischemic. And then there's a subtype here, which is called transient ischemic attack. We'll discuss that. Intracerebral hemorrhage and subarachnoid hemorrhage. Let's zoom in and talk about the acute ischemic strokes in TIA. First thing we need to know is what the heck is the difference here between a TIA and an acute ischemic stroke. A TIA is when you develop neurodeficits because of an occlusion of the vessel for whatever reason, but there is no infarction of that area, and the neurodeficits that you have don't usually last very long. We say last less than 24 hours. For an acute ischemic stroke, it's neurodeficits with evidence of infarction on CT MRI, and those deficits usually last for much longer than 24 hours. Okay, what are the potential causes of developing an acute ischemic stroke or a TIA? It really comes down to three causes: hypoxic, embolic, or thrombotic. So hypoxic causes is whenever you have a significant decrease in blood flow to the brain and less oxygen being delivered to the brain. This can happen in situations like cardiac arrest, significant shock like septic or cardiogenic shock, or in severe respiratory failure. The next one is embolic causes. There's something that's kind of popping off, a clot, and circulating up into the brain and getting stuck there. If it's coming from the heart, there's two things I want you to remember. It's either cardioembolic, things like atrial fibrillation is very, very important to remember. A left ventricular aneurysm can also be a cause. And then also if they have like a mechanical heart valve. The other thing is if you have a clot that comes up from a DVT, goes up through the inferior vena cava into the right atrium, and there's a hole between the right atrium and the left atrium where the clot flips over into the left side of the heart and then pops up and goes into the brain. That's called a paradoxical embolus. And that can happen whenever you have a hole in the atrial septum called a patent foramen ovale. So that's called a paradoxical embolus because it's coming from the right side and still throwing a clot up into the left side circulation. The next thing is thrombotic causes. So there's usually plaques within the vessel walls, and usually within small vessels like the lenticular striates, or large vessels like your internal carotid, your middle cerebrals, your vertebral basilar arteries, big large arteries that have big plaques. And you rupture or fissure the plaque and create a clot. Platelets come and plug it, lead to a clot and occlusion of blood flow. Particular things to remember for this is risk factors. So things like hypertension, things like diabetes, smoking, obesity, those are very, very important things to remember. And what's important is you can actually modify those things, as well as hyperlipidemia. Things that are non-modifiable, things you can't really fix, is old age, being male, or particular ethnicities. So things to remember for that. That covers the transient ischemic attack and acute ischemic strokes. Next one is if you have a bleed. Okay, intracerebral hemorrhage. Big thing I want you guys to remember is the particular causes. The most important one and probably the most common is hypertension. And there's very common locations for those hypertensive bleeds, such as the basal ganglia that we talked about, the pons, the cerebellum, and less common is lobar or cortical locations. The other types of causes to remember include cerebral amyloid angiopathy in older individuals who also exhibit dementia, coagulopathies like you're on anticoagulants, you had an ischemic stroke, got TPA, and it actually transformed into a hemorrhage, or you have a malignancy from someplace like the lungs, the thyroid, the kidneys, melanoma, or a choriocarcinoma. And lastly, one of the more common things is trauma. That is the big thing to remember here for intracerebral hemorrhage. Let's finish up talking about subarachnoid hemorrhage. This is another type of stroke type of pattern. Subarachnoid hemorrhages are usually due to what? Usually an aneurysm that ruptures or pops, and those are cerebral aneurysms. So cerebral aneurysms, there's different types. There's fusiform, there is what's called saccular aneurysms, and saccular berry aneurysms are more common, usually the most common type of aneurysm that will rupture. What are the reasons for those aneurysms forming? It could be particular risk factors like hypertension, smoking, ethanol, as well as what else? Drug use like cocaine and methamphetamines. The other thing is that there's a weakness within the connective tissue of that vessel wall, like in connective tissue diseases like Marfan's, Ehlers-Danlos, and polycystic kidney disease. The other less common cause is arteriovenous malformations. They're abnormal formations of arteriovenous connections that can rupture, especially in children or adolescents. But the most common cause of a subarachnoid hemorrhage is going to be trauma. But again, whenever you have a bleed, it accumulates in that subarachnoid space. Intracerebral hemorrhage, the blood accumulates within the parenchyma of the brain tissue. That covers etiology and pathophys. Now let's cover the clinical features. All right, Ninja Nerds, so now let's talk about clinical features of strokes, whether this be ischemic stroke, whether this be an intracerebral hemorrhage, whether this be a subarachnoid hemorrhage. They can all present with focal deficits depending upon the vessel that's either clotted, ruptured, one of those two scenarios here. So let's talk about the different syndromes, if you will. The first one is if you develop a clot or a rupturing of the anterior cerebral artery. What kind of neurodeficits would you show? Remember, it supplies that frontal, the medial, frontal, and parietal lobe, which is where what portion of the actual muscles and sensations come from? The lower extremities. So they'll develop contralateral weakness of the lower extremities more than the face and upper extremities, as well as contralateral sensory loss of the lower extremities more than the face and the upper extremities. Also, it contributes to what's called the prefrontal cortex here in that blue color. That is involved with a lot of our emotions and behaviors and decision making, and so this can lead to what's called abulia, which is a decreased motivation or desire to participate in certain activities, or akinetic mutism, where they don't verbally communicate or don't move because they have no willingness or willpower to do that. The next one is MCA syndrome. You either clot the MCA or pop it. What are the particular neurodeficits? Remember, MCA supplies the lateral portion of the frontal and parietal lobe. So motor-wise, you'll develop contralateral weakness of the face, upper extremities more than the lower extremities, as well as contralateral sensory loss, more of the face, upper extremities than the lower extremities. Another thing is that it supplies this green area, which is called your frontal eye fields, which control your saccadic eye movement. If your left MCA is either clotted or ruptured, it'll cause gaze deviation to that same side, the left side, called ipsilateral gaze deviation. This orange area here is called Broca's area. Broca's area is usually more commonly located on the left side, which is your dominant side. Whenever there's injury of the Broca's area, you can develop Broca's aphasia, which is called an expressive aphasia. The other one here is in purple. Purple is the Wernicke's area, again, usually located on the dominant side, which is the left side. If there is injury to that area, you can develop Wernicke's aphasia, which is also known as receptive aphasia. The next thing is you see these like maroon fibers that are running through the temporal lobe and parietal lobe. Those are your optic radiations. If you hit those optic radiations, it can cause contralateral homonymous hemianopia. What the heck does that mean? For example, if you develop a left MCA clot or rupture of that vessel, what's going to happen is you're not going to be able to see the visual fields on the right side, the contralateral side. Last thing for the MCA is if you have a stroke, whether it be ischemic or hemorrhagic, on the right MCA division, that's usually your non-dominant side. And those people develop particular types of qualities called apraxia, where their motor function's intact, they want to perform the activity, but they can't. They don't know how. And then the last one is neglect. And so they neglect sensations on the opposite side of the body. So for example, right MCA, they would neglect the sensations on the left side of their body and neglect their left visual fields. That covers MCA. Now what's important to remember is ICA syndrome can actually look like ACA and maybe even MCA syndrome with one additional feature. The reason why is if you guys remember your cerebrovascular anatomy, ICA gives off the anterior cerebral and it also gives off the middle cerebral. If you get a clot or rupture of the ICA, you could potentially not get blood flow into those two vessels. And so you could develop an ACA syndrome, which we talked about, or an MCA syndrome. The last thing is it also gives off a vessel called the ophthalmic artery, which supplies the retina. And so if there's injury to that, whether it be a clot or rupturing, you could develop a temporary monoocular vision loss called amaurosis fugax. If it's not treated or reversed, you could develop complete blindness of that eye. Okay? Next one that we have to talk about here is called your watershed syndromes. We didn't talk about this too much, but this can happen in hypoxic, ischemic, or hypoperfusion types of incidences. So watershed is the area between two big vascular territories pretty much. So for example, this territory is the ACA. This territory is the MCA. This area between them is the MCA-ACA watershed zone. Whenever you have severe hypoperfusion or severe hypoxia from cardiac arrest, shock, respiratory failure, these areas are prone to getting injured. And so if you think about your homunculus, right in the middle is where your kind of proximal upper extremity trunk and the proximal lower extremities. So proximal upper extremities, proximal lower extremities, those get hit the most. And so you can develop weakness of those areas as well as sensory loss in those areas. They call that man in a barrel syndrome. Okay? The other big watershed territory is between the PCA, which would be here, and again the MCA, which would be here. And severe hypoperfusion, severe respiratory failure, cardiac arrest, these areas can get hit and you can develop an MCA-PCA watershed infarct, which can present to what's called prosopagnosia. And basically what this means is they have visual dysfunction. So they can see somebody, but they can't make out or recognize who that person is or what that object is. Pretty sad situation there. So that's watershed infarcts or syndromes. The next one I want to talk about is your PCA syndromes. So the next one is the PCA syndrome. Now you got to remember the posterior cerebral artery supplied what structure? The occipital lobe. If you knock out the occipital lobe, that's where visual pathways kind of come. So for example, if you have a right PCA lesion of some kind, then what's going to happen is your visual fields on the contralateral side will be gone. So you could develop contralateral homonymous hemianopia. So right PCA, left homonymous hemianopia. So that's the first one. The other thing is if you knock out the dominant kind of occipital lobe area, you can also develop the inability to be able to read, called alexia, but you can still write, so you don't have any agraphia. The other thing is it hits the thalami, so it can involve the thalami. If you knock out, for example, right PCA, and you knock out the right thalamus, you can develop contralateral hemisensory losses or pain. We call that contralateral hemibody pain. In this case, right PCA, left-sided hemibody pain. The next thing is if you knock out the midbrain. The PCA supplies the midbrain. So there's different types of syndromes like Weber syndrome, which affects the third nerve, as well as your contralateral hemiplasia, so ipsilateral third nerve palsy, contralateral hemiplasia. Benedict syndrome, which is contralateral ataxia, as well as ipsilateral third nerve palsy. And Claude syndrome, which is actually the combination of Weber and Benedict syndrome. So that covers our PCA syndrome. The next one that I want to talk about is called lacunar infarcts. Now, lacunar infarcts are kind of basically, if you will, kind of a branch of the MCA syndrome, if you will, because they're those tiny little vessels that come off of the MCA. These are very high yield topics that you need to know. Lacunar infarcts is if you have those little lenticular striate arteries that rupture or have an occlusion, they can develop 5 types of syndromes that you need to remember. It's either pure motor, okay, so contralateral weakness, pure sensory, contralateral sensory loss, sensory motor, so contralateral weakness and sensory loss, ataxic hemiparesis, where you have weakness as well as loss of coordination, and dysarthria clumsy hand syndrome, so difficulty with speech. These are big high yield information to remember for lacunar infarcts. Now, let's talk about the other two, which is the basilar artery and vertebral artery. All right, so the basilar artery, this supplies your pons as well as the parts of your cerebellum. So, basilar artery, particularly its branches directly, supply the medial pons. So if you injure that, clot or rupture of it, you can develop ipsilateral 6th nerve palsy, so abducens nerve palsy. You can also hit that corticospinal tract, so you can develop contralateral weakness. You also hit the medial lemniscus, so you cause contralateral sensory loss of like touch and proprioception of vibration. Now, off of the basilar comes this vessel here called your ICA. So you got to remember that gives off what's called the ICA. Now, the ICA supplies the lateral pons. So if you hit the ICA, it can cause ipsilateral 5th and 7th nerve palsy. So 5th supplies mastication muscles, so you have weakness of chewing muscles on the same side, and facial weakness on the same side. It also hits the cochlear nuclei, so you can develop deafness. It hits the vestibular nuclei, so you can develop nausea, vomiting, vertigo, nystagmus. It also hits the spinal thalamic tract, so you develop contralateral loss of pain and temperature sensations. You also hit the trigeminal tract, and so because of that, you can develop ipsilateral loss of pain, temperature, touch, vibrations of the same side of the face. And then lastly, you hit the descending sympathetic tracts, and you can develop ipsilateral Horner syndrome, characterized by anhidrosis, meiosis, and ptosis. The last thing is that also the basilar artery gives off what's called the superior cerebellar artery, which is this top one. The AICA and the superior cerebellar artery supply the cerebellum. If there's injury to those vessels, you can develop ataxia, dysmetria, and dysdiadokinesis. The next thing I want to talk about is the vertebral arteries. So if you hit the vertebral arteries, whether you clot them off or whether you pop them, you're going to cause particular injury to the medulla, as well as parts of the cerebellum. The medial medulla is primarily given off by the vertebrals and what's called the anterior spinal artery. If you knock that out, you hit the hypoglossal nerve. So you can develop ipsilateral 12th nerve palsy, so the tongue deviates to the same side. You also develop contralateral weakness because you hit the corticospinal tracts. You also develop contralateral sensory loss of touch, vibrations, proprioception because you hit the medial lemniscus. Then you have the lateral medulla. Remember, the vertebral arteries give off this branch off the side called the pica, and the pica supplies the lateral medulla. If you hit the nucleus ambiguus, which controls glossopharyngeal, vagus, a little bit of accessory, you can develop dysphagia, dysarthria, and uvular deviation. The other thing is if you hit those vestibular nuclei, you get nausea, vomiting, vertigo, nystagmus. If you hit the spinal thalamic tract, you get contralateral loss of pain and temperature sensations. If you hit the spinal trigeminal nucleus, you get ipsilateral loss of facial sensations, touch, pain, temperature, vibration, proprioception. And if you hit the descending sympathetic tract, you get ipsilateral Horner syndrome, ptosis, meiosis, and anhidrosis. That covers the vertebral artery syndrome. The last thing that I want to hit on that are particular clinical features in these is specific with ICH and subarachnoid. ICH can present with a headache, but also increased intracranial pressure signs because Monroe Kelly doctrine says inside the skull is blood, CSF, and brain. One of those increases, it increases the intracranial pressure. So those can present with nausea, vomiting, cranial nerve deficits, and the Cushing's triad, hypertension, bradycardia, and irregular respirations. Subarachnoid hemorrhage presents with the classic thing within your vignettes, the worst headache of their life or a thunderclap headache. They also can develop meningeal signs because of the blood irritating the meninges, such as photophobia. They can develop neck stiffness and nuchal rigidity, as well as Brzezinski's and Koenig signs. And they also have increased ICP because of blood within the brain cavity. Okay, that covers clinical features. Let's now talk about diagnosis. All right, engineers, now let's talk about the diagnosis of these types of strokes, whether it be ischemic, intracerebral, or subarachnoid, and even potentially TIA. Well, TIA, we know that there will be no evidence, right, of infarction on the imaging. So if we went straight into acute ischemic stroke, first thing that we should do is get a STAT CT scan of the head, a non-contrast. The reason why I always want to rule out an ICH or a subarachnoid hemorrhage first. Next thing is sometimes if you're good, you can pick up a really bright or hyperdense MCA, which means it's a fresh clot within that vessel, or a hyperdense basilar, meaning that there's a fresh clot within the basilar artery. Now sometimes you won't be able to see it, but as this stroke begins to evolve over time, the tissue of the brain will start to become darker, also known as hypodense. So you might see hypodensities that are evolving over time as the stroke progresses. The next thing is sometimes we can obtain a CTA. So let's say that we don't see an ICH or subarachnoid, we see some hypodensities or hyperdense signs, MCA basilar, we get a CTA. That will show us the vessels with contrast and show us where there's a clot or a filling defect, where the occlusion is. Next thing is an MRI is most sensitive. Because of timing, it's not the first thing that you should get. It's a little bit later. But it's going to show us two sequences that you want to know, DWI, ADC. The diffusion weighted image of the DWI will show up hyper intense in the area that they stroked. And then the ADC will show, the apparent diffusion coefficient, will show hypo intense in that area that they stroked out, or dark. That's acute ischemic stroke. Intracerebral hemorrhage, first thing, STAT CT scan of the head, non-contrast. You'll be able to see if they have a bleed in one of the locations that we talked about before. If there is a bleed and we see it within the parenchyma, it's an ICH. You also want to know, is there blood that extended into the ventricles? That's IVH. If the blood did extend into the ventricles, did it puff up the ventricles? Do they have hydrocephalus? And the most important thing is also how big is the bleed? Use the ABC divided by 2 formula to determine the volume of the bleed. Next thing is later, not acutely, later, if we want to evaluate the causes of the bleed, we can do an MRI. MRIs are good because if we use what's called the SWI sequence, it'll show a hypointense kind of hole, if you will, where the actual hemorrhage occurred within the brain parenchyma. The other thing is think about other causes. Another image to obtain is a CT chest, abdomen, pelvis. Why? Malignancy. See if there's a malignancy somewhere that actually spread to the brain, and that's why they have this bleed. All right, the last one that I want us to talk about is subarachnoid hemorrhage. So again, stat CT scan. You see the theme. Get a stat CT for all of these for focal neurodeficits. And so what we're going to do is look for blood in the subarachnoid space. Usually you see whiteness within the sulci. You see it in the sylvian fissures. You'd see it potentially within the cisterns of the actual central nervous system. Sometimes you can even see the blood spilling into the ventricles, causing IVH and even hydrocephalus. So big thing to think about for that. If you do see that subarachnoid pattern, the next thing you can do is one of two tests. You can get a CTA, an angiogram filling up the vessels, looking to see where the aneurysm is, or AVM, and where the actual cause of the bleed is. So CTA is good for finding where the bleed is and helping for intervention. The next thing you can do is if you don't get a CTA or it's not visible on the CTA, you can do a lumbar puncture. A lumbar puncture you take and you'll have blood coming into the CSF tubes that doesn't clear as you continue to collect. And also when it gets spun down, a classic sign is this yellowish appearance called xanthochromia due to the breakdown of the heme pigments that are within the blood of the CSF. The gold standard to definitely find where the subarachnoid hemorrhage is coming from is a digital subtraction angiogram. You visualize the vessels in a fluoroscopic way. So that would be the definitive way. The last thing that I want to talk about is there's a bunch of other tests that we can do to determine, the other etiologies and causes of subarachnoid hemorrhage. What are other tests we could order? A CBC. You could order a BMP, coag parameters such as PT, PTT, and INR. You could also order troponins, a 12-lead EKG, and an echocardiogram is also pretty helpful to evaluate underlying etiologies. All right, we covered diagnosis. Now let's talk about treatment. All right, engineers, we're at the last part of this stroke lecture, whether it be ischemic or hemorrhagic strokes, or even TIA, we're at treatment. First thing is TIA. How do we treat TIA? Well, TIA is actually more particularly managing it through what's called risk stratification. So determining their risk of actually developing a subsequent type of acute ischemic stroke. How do we risk stratify them? One of the common calculations is utilizing what's called the ABCD2 score. Age, blood pressure, clinical features, duration, and diabetes. So if their age is greater than or equal to 60 years old, they get a point. If their blood pressure is greater than or equal to 140/90, they get a point. Clinical features. If they have only aphasia and no other deficits, that's 1 point. If they have aphasia and other deficits like weakness, that's 2 points. Duration. If it's less than 60 minutes or an hour, it's 1 point. If it's greater than 60 minutes or an hour, greater than or equal to, then it's going to be 2 points. And the last is if they have diabetes, whether it's type 1 or type 2, they get a point. Now, based upon that, we can get a score, and that'll determine our risk. If it's less than 3, there's a relatively low risk of developing an acute ischemic stroke within a certain amount of time. 4 to 5, moderate risk, and 6 to 7, high risk. So with TIA, sometimes what we're going to talk about here is kind of reducing the risk factors that they may have that are increasing their risk of acute ischemic stroke. So let's talk about acute ischemic stroke, the acute treatments, as well as some of the modifications of risk factors. So acute ischemic stroke, we have a clot within the vessel, whether that's an embolic clot or whether that's a thrombotic clot. We need to treat them, and we have a very limited time window because as tissue starts dying, you start losing neurological function. So the first thing to think about is TPA, tissue plasminogen activator. You give this IV preferably. What do we need to know? When was their last known well? When was the last time we saw them and they were normal? If it was between 3 to 4.5 hours, then you can give them TPA. As long as they have no ICH, subarachnoid hemorrhage, they have no recent ICH, they have no active bleeding, they don't have really, really high blood pressure, all of the contraindications to TPA, as long as they have no contraindications, the last known well was 3 to 4.5 hours, since that kind of last known seen normal, and they have visibly seen neurodeficits, you give them TPA. TPA works by doing what? increasing the concentration of plasmin. Plasmin is a fibrin digesting enzyme which breaks down the clot, okay? What's another option? Let's say that they're outside of that TPA window. They're at 6 hours and up to 24 hours. We can actually go in with a catheter or a stent retriever and suck that clot out. And that's called thrombectomy. So not only is that good for outside of the time window, but it's also good for those who have big clots within big vessels, like the MCA, the ICA, or the vertebrobasilar arteries. If they have clots in those, you can actually give them TPA, and as you can also take and do a thrombectomy for those. The next thing that you need to remember is that what if they have really bad stenotic carotid arteries, whether it be common carotid or internal carotid arteries, really stenotic, and that was the reason for their stroke. We should get rid of those plaques and all that stenotic vessel that's there. And so we utilize carotid revascularization therapies. You can either put in a stent, which is called a carotid artery stent, or you can actually go in there surgically and cut the plaque off, which is called a carotid endarterectomy. But these are important, especially if you have strokes and really significant stenosis of the vessel that's greater than 70%, preferably. These are the big therapies. The other things are trying to reduce some of the risk factors for these thrombotic strokes, which is what? Do they have hyperlipidemia? If they do, put them on statins. Do they have high blood pressure? Lower it with antihypertensives. Do they have hyperglycemia? Lower their glucose by giving them insulin or increasing their anti-diabetic medications. Do they smoke? Decrease their smoking, smoking cessation, things like Wellbutrin, Chantix, nicotine patches, okay? And if it's obesity, lose weight. Modifying those types of things that can be modified reduces the risk of thrombosis. The other thing is you can also reduce the risk of thrombosis if they have plaques by giving them drugs that'll block the platelets from sticking to that thrombotic plaque or to those actual plaques. What are those? Antiplatelet agents. These are things like aspirin or clopidogrel, also known as Plavix. These are also great, especially if someone has a stent. Stents are also high risk for thrombosis, so sometimes when people have stents, not only do we cover them with the stent for revascularization, we also put them on antiplatelets as well. So again, risk factor modification, antiplatelets to reduce the risk of thrombosis. The other thing is, what if it's not actually a thrombotic cause, it's a cardioembolic cause? So there's an actual problem with the heart that's popping emboli out. Well, in those situations, whether it's atrial fibrillation, whether it's a mechanical heart valve, whether it's a left ventricular aneurysm, whatever it is, you anticoagulate them. And there's different options. Warfarin or direct-acting oral anticoagulants such as apixaban, rivaroxaban, which are factor Xa inhibitors, or dabigatran, which is a thrombin inhibitor. That covers that part. Now the last thing is sometimes if you get a really bad stroke, a large hemispheric stroke, like the MCA division, the entire division gets knocked out, that sucker swells and it causes a lot of edema. And so sometimes in that situations of high intracranial pressure, cerebral edema related, you can pop the skull off doing what's called a hemicraniectomy. And you can also try to pull some of the salt from the other areas out of those cells, dehydrating the brain with mannitol or 23.4% hypertonic saline, sometimes even 3%. That covers TIA, acute ischemic stroke. Let's talk about ICH. All right, so now we're talking about intracerebral hemorrhage. So whenever someone has an intracerebral hemorrhage, think about the causes. So the causes, the first one that I want you guys to think about quickly is, were they on any anticoagulants? Because if they were on anticoagulants, I have to reverse that so they don't keep bleeding and worsening that already present stroke. So reversing the coagulopathy. If they took warfarin and you find out, give them vitamin K and PCC, which is prothrombin complex concentrate, or FFP, fresh frozen plasma. That's replacing the clotting factors basically. If they took heparin, give them protamine sulfate. If they took a DOAC, like apixaban, rivaroxaban, then you give them PCC, prothrombin complex concentrate. You can also either give FFP, fresh frozen plasma, but there's a newer drug called andexanet alpha, which is also believed to be another kind of specific target for those factor Xa inhibitors, apixaban and rivaroxaban. Finally, if they took dabigatran, a thrombin inhibitor, there's a special antidote for that called idarucizumab. Very important to remember that one. Lastly, if they took TPA because they had an ischemic stroke and they hemorrhaged and converted, what do you give them? TXA, tranexamic acid, and cryoprecipitate, which is replacing the fibrinogen. Okay, that's the first thing. What was another very important cause, the most common cause of ICH? Hypertension. Lower their blood pressure and keep it lower. So we aim for a blood pressure, some will say less than 140, some will say less than 160, okay? It's nice to have a nice range there. How do we do that? It's best to control it in the initial segments of this ICH with IV infusions or pushes, like nicardipine as an infusion, labetalol as an IV push, or hydralazine as an IV push. And hydralazine is better whenever they have very low heart rates and you can't give labetalol. The next thing that you want to think about is whenever they have all of that blood accumulating into that area of the brain, depending upon where it is, that can increase the intracranial pressure. Monro-Kelly doctrine. Blood, CSF, brain, one of them increases, it can increase ICP. You can pull the skull cap off, and that can allow for the brain to swell out through that to reduce the risk of herniation. You could also pull and evacuate out that bloody clot or bloody hemorrhage, and you can also put a EVD into the ventricles, because if blood extends into the ventricles, it can cause hydro. That increases CSF, that increases ICP. So putting an EVD in is also a measure there. As well as the ones that we talked about here above, 23.4% hypertonic saline, as well as mannitol and acute ICP crises. Last but not least here is the subarachnoid hemorrhage. Now, subarachnoid hemorrhage, the most important thing to do whenever they come in is to coil or clip the aneurysm if it is an aneurysmal bleed, which is the most common cause other than trauma. How do we do that? We either take and put these coils that actually kind of embolize or block off any more bleeding from that area, or we take and clip onto the base of that, kind of the neck of the aneurysm. That's the first thing. The second thing is controlling their blood pressure, either pre-clipping is very important because we don't want to re-bleed or rupture that blood even more into the subarachnoid space. And so again, utilizing the same things, nicardipine infusions, labetalol IV pushes, hydralazine IV pushes if their heart rates are low and you can't give labetalol. These are important. Whenever they're pre-clipping or pre-coiling, keeping their blood pressure less than 160 millimeters of mercury systolic is very, very important. Afterwards, after they're actually secured, the blood pressure is kind of like a little bit more variable and relaxed. The next thing that you want to think about is the same thing we talked about here with ICHs. If you have blood, again, three things: blood, CSF, brain. One of those increases inside of the skull increases ICP. You got blood. And if the blood gets into the ventricles, it can cause IVH and therefore hydro. That's increasing CSF. What do? We can do some of the same measures. Usually craniectomy is not a big thing. Usually there's no evacuation of that blood. It's more likely we put in an external ventricular drain and control acute ICP crises with 23.4% hypertonic saline or mannitol. The next thing that you guys really want to remember here, that is a very significant thing, is vasospasm, which can lead to ischemia to the brain and actually cause strokes, ischemic strokes. So subarachnoid hemorrhage can cause vasospasm leading to ischemic strokes, and this can happen anywhere from days 4 to 14 after the bleed. How do we prevent this? Well, one of the ways is we actually cause induced hypertension. We actually increase their blood pressure to push as much blood through those little spastic vessels. Sometimes we target high blood pressures. The other thing is we can give a drug called nimodipine. Nimodipine has been shown to reduce outcomes of vasospasm, which is a calcium channel blocker to try to relax those spastic vessels. And lastly, the most important thing is actually going in via an intra-arterial method, via interventional radiology, and squirting intra-arterial dilators into the area to relax those vessels. That is important, and that covers the treatment of strokes. All right, Ninja Nerds, in this video we talk about strokes, ischemic, hemorrhagic strokes, as well as TIA. I hope it made sense. I hope that you guys did enjoy it, and as always, until next time.